Welcome to the Deep Dive. Today, we're going to get into something we all experience. Stress.
Absolutely.
We've got some really interesting material here, surveys about how stressed people are feeling, detailed breakdowns of what actually happens inside us,
Physically and mentally, yeah.
and what happens when things get, well, overwhelming, leading to conditions like PTSD, dissociative disorders,
No.
stuff like that.
It's a big area.
So the mission today is really to unpack stress from the everyday kind right through to the impact of serious trauma.
And it's key to remember, like you said, stress isn't always the enemy. Our sources talk about eustress.
Right, the good stress.
Yeah, the kind that pushes you, helps you focus, like before a big game or presentation, that little edge.
Makes sense.
But then there's distress. That's the chronic, grinding kind that, really takes a toll. And that 2017 Stress in America survey, it showed a lot of people were feeling that significantly.
Okay, so when we're talking stress today, we mean this whole process, right? Physical feelings, thoughts, how we act, emotions, all reacting to what we think is being demanded of us.
Exactly. It's a perception thing.
And our bodies are built for short bursts, but the long haul, that's where the effects, good or bad, really show up. We're focusing on when it gets pushed too far, especially with trauma.
And to get that, we need to look at the immediate reaction, the classic fight or flight. Our sources point to the amygdala, sort of the brain's emotional alarm bell. It spots danger and sends a signal straight to the hypothalamus.
Okay, hypothalamus,
Yeah.
the command center. It kicks off the autonomic nervous system that controls all the automatic stuff, breathing, heart rate.
Precisely. And that system has two main modes. The sympathetic nervous system, that's the gas pedal, gives you that instant energy surge.
Right.
It tells the adrenal glands to pump out epinephrine adrenaline.
The adrenaline.
That's what gets your heart pounding, breathing faster, muscles tensing. You're ready to move now.
But what if you can't just run or fight? If the threat is ongoing or different? That's the HPA axis, isn't it? Another hypothalamus pathway.
Spot on. For stress that sticks around, the hypothalamus releases CRH. That tells the pituitary gland to release ACTH.
Okay, another acronym.
Yes. ACTH travels to the adrenals and tells them to release cortisol.
Cortisol. Heard of that one? The stress hormone.
That's the one. Its job is keeping your cells fueled, diverting glucose to the brain, basically keeping you on high alert for longer. It's like the body's long-term emergency power.
And the sources also mentioned a freeze response.
Yeah.
That was interesting.
Yes, it's another autonomic reaction. If the danger feels totally overwhelming, inescapable, sometimes the system just shuts down, hits pause.
Makes a grin kind of sense.
It does. And these are all meant to be temporary states. Fight, flight, freeze.
Mm-hmm.
Get through the danger, then calm down. That's the job of the parasympathetic nervous system.
The rest and digest system. The brake pedal.
Exactly. It slows the heart rate, lowers the stress hormones, brings you back to baseline.
But if the stressors keep coming, if you're constantly under pressure, that recovery gets disrupted.
And that's the danger. Being stuck in high alert, our sources really emphasize how damaging that is long term. It can contribute to so many health problems.
Mental and physical. I saw one source even suggested something like 90% of diseases might have links to chronic stress. That's huge.
It's a staggering figure, and it really drives home why understanding this matters. Which brings us to PTSD, post-traumatic stress disorder.
Okay.
And the key thing here is it's not just soldiers. Anyone can develop PTSD after a trauma that feels just way outside normal human experience.
The sources listed things like abuse, assault, natural disasters, even witnessing horrific events.
Right. The common factor is often that feeling of intense helplessness, powerlessness during the event.
So what does PTSD actually look like,
Yeah.
symptom-wise?
The APA breaks it down into 4 main clusters. First, intrusive re-experiencing. The trauma just keeps coming back. Unwanted. Flashbacks where you feel like it's happening again. Nightmares, distressing memories popping up. Strong reactions to reminders.
That sounds awful.
It is. Then there's avoidance. Trying hard not to think about it or avoiding places, people, activities, anything linked to the trauma.
Trying to shut it out?
The third is alterations in arousal and reactivity.
Like being jumpy.
Yeah, exaggerated startle response is classic. Also, irritability, angry outbursts, maybe reckless behavior, hypervigilance, feeling constantly on guard, and sleep problems. Big time.
Okay. And the last one?
Negative alterations in cognition and mood. This is about changes in thoughts and feelings. Distorted negative beliefs about yourself or the world. Fear, guilt, feeling detached.
Detached.
Yeah, emotionally numb, losing interest in things, unable to feel positive emotions, and sometimes difficulty remembering parts of the trauma itself. That's dissociative amnesia.
And you mentioned dissociation. Can that show up directly in PTSD too, like feeling unreal?
Yes, absolutely. Some people with PTSD have prominent dissociative symptoms, feeling detached from their own body or surroundings, almost like watching themselves from outside, or having flashbacks where they lose touch with the present.
Wow. Okay, and how long do these symptoms have to last for a PTSD diagnosis?
More than 1 month. That's a key criterion. The DSM-5 lays it all out: the trauma exposure, the specific symptom clusters, the duration, the impact on life.
And there are subtypes, like with those dissociative symptoms you mentioned, or a delayed start.
Exactly. Sometimes the full picture doesn't emerge until 6 months or even later after the trauma. And yes, there's a subtype specifier for PTSD with prominent dissociative symptoms, like depersonalization or derealization.
Depersonalization,
Yeah,
feeling detached from yourself.
Yeah.
Derealization, feeling like the world isn't real.
that's right. And there's a handy acronym in the materials: trauma, to remember the basics; traumatic event, re-experiencing; avoidance, unable to function; month or more duration, increased arousal.
Trauma. Useful shorthand. So how common is this?
More common than many think. Lifetime prevalence is around 7–8% of the population. In any given year, maybe 8 million adults in the U.S. are dealing with it.
And it affects women more.
Yes, the rates are higher for women, around 10%, compared to maybe 4% for men in the general population.
What about military populations? We hear a lot about that.
Definitely. Rates vary by conflict era. For IOEF veterans, estimates are like 11–20%. Vietnam veterans, some lifetime estimates go as high as 30%.
That's incredibly high.
It is. And military sexual trauma, MST, is a huge factor too. Really high rates reported by both women and men. Assault, harassment. It's crucial to know that a significant number, maybe half or more, of veterans dealing with MST are men.
Sobering numbers.
Yeah.
What makes someone more likely to develop PTSD after trauma? Are there risk factors?
Yes, several factors. Things present before the trauma, like being younger when it happens, being female, having a personal or family history of psychiatric issues, lower education. For veterans specifically, things like being from a racial minority group, lower rank or socioeconomic status, more or longer deployments, previous psychological problems, and crucially, lack of social support. That one comes up a lot.
Social support is key. And does PTSD affect physical health too?
Oh, absolutely. The link with cardiovascular disease is particularly strong, but also increased risk for cancer, diabetes, obesity, GI problems, arthritis, a whole range. And the immune system can be affected too, even a higher risk of dementia later on.
Wow. And mentally,
It's
co-occurring conditions.
Very common. Depression is diagnosed in up to half of people with PTSD. Other anxiety disorders, substance use disorders, maybe 40–50% comorbidity there. Sleep disturbances are almost universal. And sadly, a significantly increased risk of suicide, especially if there's a history of childhood abuse or MST.
That link with suicide is really concerning. You also mentioned traumatic brain injury, TBI. How does that fit in?
It's a major complicating factor, especially for combat veterans where blast injuries are common. Maybe up to 20% have had a TBI. The symptoms, concentration problems, irritability, sleep issues, can overlap a lot with PTSD.
Making diagnosis tricky.
Very. And having a TBI seems to be a strong predictor for developing PTSD after deployment. But it's not just veterans, athletes, accident victims, shaken baby syndrome. TBI is relevant in many trauma contexts. Screening is vital.
Right. And you said symptoms can be delayed.
They can. Someone might seem okay initially, and then symptoms emerge months, even years later. Early intervention is ideal, but awareness needs to be ongoing.
Are there things that predict a better outcome?
Yes, thankfully. Strong social support. There it is again. Good physical and mental health before the trauma. And sometimes, actually, having symptoms start fairly quickly after the event can predict a better recovery path, oddly enough.
Interesting. Now, the materials also mentioned acute stress disorder. How's that different from PTSD?
The main difference is time. Acute stress disorder happens after a trauma, same triggers as PTSD, but the symptoms, intrusion, avoidance, arousal, etc., last from 3 days up to 1 month.
So if they resolve within that month, it's acute stress disorder.
Correct. If they persist beyond a month, the diagnosis usually shifts to PTSD. It's like a very intense but shorter term reaction.
Got it. Okay, shifting gears slightly. Compassion fatigue.
Yeah.
Or secondary traumatic stress.
This is about the helpers, right?
Exactly. It's so important. This affects the people, healthcare workers, therapists, first responders who are constantly working with traumatized individuals. It's like the emotional cost of caring.
Absorbing that trauma indirectly.
That's a good way to put it.
Yeah.
You're exposed to horrific stories, intense suffering, day in, day out, and it can lead to this profound emotional and physical exhaustion.
What does that look like? The symptoms?
Feeling totally overwhelmed, drained, maybe unable to function properly, having intrusive thoughts or images related to your patient's trauma, difficulty separating work from home life, becoming cynical, irritable, maybe dreading work. That sounds incredibly draining.
It really is. Pessimism, depression, maybe turning to unhealthy coping mechanisms like substances, withdrawing socially, questioning your own competence, losing hope, insomnia, low self-esteem. It's a heavy burden.
For certain fields, higher risk.
Yes. The sources mention areas like hospice, pediatrics, emergency departments, oncology, forensic nursing, places where you see a lot of suffering in difficult situations.
And personal factors.
Things like having unrealistic expectations of yourself, getting overly involved, being inexperienced, or going through your own personal crisis can make someone more vulnerable too.
But it's manageable.
Hmm.
The sources talk about self-care.
Absolutely crucial. Making time for joy, little escapes, scheduled breaks, getting your own health care, avoiding self-medication, consciously reframing negative thoughts, practicing
Right.
gratitude. Looking after yourself isn't selfish, it's essential to keep doing the work.
That focus on the impact of trauma leads into trauma-informed care, right?
Yes, it's a framework, an approach, recognizing just how common trauma is. Our materials cite staggering numbers, like 55–99% of women in substance use treatment have trauma histories, 85–95% in mental health treatment.
Huge numbers.
And the ACE study, Adverse Childhood Experiences, showed that connection clearly. Childhood trauma increases the risk for so many physical and mental health issues later in life. Almost 2/3 of people in that study reported at least one ACE.
So trauma-informed care means service systems understanding this prevalence, understanding the impact, how it affects people seeking help, and importantly, how the system itself could accidentally re-traumatize someone.
Precisely. It's about creating safety, trustworthiness, collaboration, empowerment, shifting the question from what's wrong with you to what happened to you.
A fundamental shift. Okay, let's talk treatment for PTSD. What works?
Psychotherapy is really the first-line treatment. The therapies with the strongest evidence are types of cognitive behavioral therapy, CBT. Cognitive processing therapy, CPT, is one. That focuses on identifying and changing those unhelpful, often upsetting thoughts connected to the trauma, challenging beliefs about safety, trust, control,
Okay.
and prolonged exposure, PE therapy. This involves carefully, gradually confronting the trauma memories, feelings, and situations that the person has been avoiding, helping them learn that the memories themselves aren't dangerous.
Sounds intense, but effective.
It can be intense, yes, but it has very strong evidence behind it. Then there's EMDR, eye movement desensitization, and reprocessing.
Right, with the eye movements, how does that work?
It involves focusing on the trauma memory while engaging in bilateral stimulation, like guided eye movements or tapping. The theory is it helps the brain process and integrate the traumatic memory in a less distressing way. Also good evidence for EMDR.
And somatic experiencing focuses on the body.
Yes, SE works with the physical sensations tied to the trauma, helping release that stored traumatic energy. Less large-scale research than CBT or EMDR, but helpful for many.
Any self-help tools mentioned?
Yeah, the PTSD Coach smartphone app from the VA got a mention. Apparently, veterans report high satisfaction with it for managing symptoms day to day.
Good to know. What about medication? Does it have a role?
It does, often used alongside therapy. The FDA has approved 2 SSRI antidepressants, sertraline and paroxetine,
SSRIs.
though the sources note paroxetine can sometimes cause issues if stopped abruptly. Other meds often recommended as first line, even if off-label, include another SSRI, fluoxetine, and an SNRI called venlafaxine.
Okay. What's not recommended?
Benzodiazepines, drugs like Valium or Xanax, generally not recommended for PTSD. The evidence suggests they aren't effective for the core symptoms and can actually be harmful, potentially interfering with therapy or leading to dependence.
Good to know. Any other meds used?
For symptoms that don't respond well, other options might be tried. Other antidepressants, maybe anticonvulsants like topiramate. There's some interest in vortioxetine. And sometimes antiadrenergic drugs like prazosin are used specifically for nightmares, though blood pressure needs watching.
Medicine for nightmares, right?
Yeah. Occasionally antipsychotics for severe symptoms, but it's complex. The key takeaway is often combining medication with psychotherapy gives the best results.
Makes sense. And nursing interventions. What's the focus there?
During really acute phases, like when someone's having intense flashbacks, reassurance and safety are paramount. helping them recognize avoidance patterns, build social support, challenging those negative thoughts, always prioritizing safety,
Right.
and managing the arousal symptoms, helping with sleep hygiene, maybe meds for sleep short term, teaching adaptive ways to manage anger. The American Nurses Foundation even has a PTSD toolkit for nurses.
Useful resource. And the materials listed general stress reduction techniques too, didn't they? Relaxation, reframing thoughts, sleep, exercise, cutting caffeine.
Yeah, all that good stuff. Connecting with people, finding meaning, meditation, mindfulness. Basic but powerful tools for managing stress in general, which definitely helps with PTSD recovery too.
Okay. Now let's move into dissociative disorders. DDs, this feels like a related and distinct area.
It is. Dissociation itself is a disturbance in the normal integration of consciousness, memory, identity, perception. It's often seen as an unconscious defense mechanism against overwhelming anxiety, usually stemming from trauma.
So it's a way of mentally escaping.
In a sense, yes, a way to cope when reality is unbearable. We might all experience mild dissociation, getting lost in a book, daydreaming, but in DDs, it's much more severe, persistent, and causes significant problems.
Does it overlap with PTSD?
Often, yes. Dissociative symptoms can be part of PTSD, as we discussed, but dissociative disorders are distinct diagnoses where dissociation is the primary feature. Importantly, though, reality testing, knowing what's real, generally remains intact, unlike in, say, psychosis.
How common are these disorders?
Estimates suggest maybe 2% of people meet criteria for a DD, more commonly diagnosed in women, but episodes of depersonalization or derealization, surprisingly common.
Yeah.
Maybe almost half of U.S. adults have experienced at least one. Yeah. Though having an episode isn't the same as having the disorder, dissociative amnesia affects maybe 1 to 2.6%. They're often overlooked or misdiagnosed, and they frequently co-occur with other issues: substance use, depression, anxiety, eating disorders, personality disorders, and PTSD, of course.
High comorbidity.
And risks. Definitely increased risk for suicidal thoughts and behavior, self-harm, sleep problems, difficulties with work and relationships.
What's the underlying theory? Still trauma?
Primarily, yes. Especially severe repetitive trauma starting in childhood. It's seen as a protective strategy that becomes ingrained. Biologically, there seem to be differences in brain activity areas involved in emotion and control. Neurological conditions can sometimes cause dissociation, too.
Genetics. Other factors.
There seems to be some genetic link higher rates in families, and psychosocially, learning theory suggests it can be a learned way to regulate overwhelming emotions. Culturally, it's important to distinguish DDs from accepted trance states found in some cultures.
Right. So what are the main types of dissociative disorders?
Okay, first is depersonalization derealization disorder. This is characterized by persistent or recurrent feelings of detachment, either from your own mental processes or body, depersonalization, or from your surroundings, derealization. Things feel unreal, foggy, distorted, but again, the person knows it feels unreal.
Like the vignette about the woman feeling unreal after her son's diagnosis.
Exactly that kind of feeling. Then there's dissociative amnesia. This is an inability to recall important personal information, usually related to trauma or stress, that goes beyond normal forgetting.
Forgetting key things about yourself.
Yes. It can be selective for certain events or more generalized. A subtype is dissociative amnesia with fugue. Fugue means flight. So the person not only has amnesia for identity or personal history, but also suddenly travels away from home, confused about who they are.
Like the lawyer after 9/11 in the example who had the fugue linked back to Vietnam trauma.
Precisely. It's quite dramatic when it happens. And apparently 20% of veterans report amnesia for combat experiences.
That's significant. Okay. And the third main type.
Dissociative identity disorder, or DDI. This used to be called multiple personality disorder.
Right.
DD involves a disruption of identity, characterized by 2 or more distinct personality states, often called alters. These alters can have different names, traits, ways of speaking, even different memories. There are recurrent gaps in recall of everyday events, personal info, or the trauma itself. People often report losing time.
And this is linked to very severe childhood trauma.
That's the prevailing understanding. Severe, inescapable, repetitive trauma, usually before age 9, where dissociating into different identities becomes a survival mechanism. Prevalence is estimated around 1%, maybe higher in psychiatric settings, often underdiagnosed, more common in women. High comorbidity with borderline personality disorder, high risk of self-harm.
And it's controversial.
It is, yes. There's debate within the psychiatric community about its diagnostic validity and how it presents, but it's in the DSM-5. The vignette of the woman whose alters emerged during evaluation linked to childhood abuse illustrates the classic presentation.
It sounds incredibly complex to assess and treat.
It really is. Assessment starts with ruling out physical causes, head injury, epilepsy, substance effects. Then a very careful psychiatric history is needed. Listening for inconsistencies, memory gaps, reports of feeling unreal, finding items they don't recognize buying, others saying they acted like a different person.
Looking for clues.
Exactly. Asking about missing time, blackouts, hearing voices, which might be alters. History of abuse is critical. There are specific questionnaires, too, like the Dissociative Experiences Scale, and assessing safety, suicide, and self-harm risk is very high, especially in DID, plus assessing comorbid conditions and how it's impacting their life.
What are the goals of treatment?
Short term, safety is always number one, building trust, managing acute distress. Longer term for DID, the goal is often integration, helping the different identity states work together more cohesively or fuse. For all DDs, processing the underlying trauma, improving coping skills, managing anxiety, and improving daily functioning are key.
How do you approach someone experiencing dissociation?
Gently. With emotional presence, creating safety and building trust are foundational. Provide reality orientation if needed, but gently. Validate their distress without validating the dissociation itself. Help them connect feelings with the dissociation. Teach grounding techniques.
Grounding, like focusing on the present moment.
Exactly. Using the senses, what do you see, hear, smell right now? Feeling your feet on the floor, it helps anchor them back to the present when they feel detached. Also teaching self-soothing strategies, encouraging journaling, supporting therapy.
What kinds of therapy are used?
Similar approaches to PTSD often help, adapted for dissociation. CBT, DBT, dialectical behavior therapy is very helpful for emotional regulation and distress tolerance. EMDR can be used carefully. Phase-oriented therapy is common for destabilization first, then trauma processing, then integration. Group therapy can provide support.
And medications.
There are no specific FDA-approved meds for dissociation itself, but meds like antidepressants or anxiolytics are often used to treat the common co-occurring symptoms, depression, anxiety. An ongoing assessment for substance use and safety risks remains vital throughout treatment.
How do you know if treatment is working?
Evaluation focuses on outcomes. Is the person safer? Is acute anxiety reduced? Are they functioning better in daily life? Are the dissociative symptoms, amnesia, fugue states, depersonalization, switching between alters becoming less frequent or intense? That indicates progress.
This has been incredibly informative, a real deep dive into stress, trauma, PTSD, and these complex dissociative disorders.
It really covers a lot of ground, from the basic biology of stress,
To these specific symptoms and lived experiences of conditions like PTSD,
the impact on caregivers with compassion fatigue,
and the unique challenges of dissociative disorders, often rooted in early trauma.
and understanding all this, it's not just academic, is it? It helps us understand ourselves and others better.
Absolutely. It equips us to be more supportive, more compassionate.
Whether it's for ourselves, our friends, family, colleagues, or thinking about healthcare and community support systems.
Which leads to a final thought for you, our listeners. We've heard how prevalent trauma and intense stress are. So consider this. What if our society truly developed a deeper, more widespread understanding of these responses? Not just knowing the terms, but grasping the impact.
How might that change things?
Yeah, how might that shift our approaches to mental health, to education, to workplace policies, even just how we interact with each other day to day? Could we build more genuinely supportive and effective communities?
Something to definitely think about.
We encourage you to explore the resources mentioned and reflect on these ideas. Thank you for joining us for this deep dive.